from there. So we might sort of start from the top down and work our way towards the fingers, and we will, whether it ends before an hour or whatever, but it will end in an hour regardless.
Yeah.
We've got things to do. Maths is on the final reunion, so we don't want to miss that because there'll be some fireworks tonight, and that's being recorded as I speak as well. Did anyone want to start us off with any cases or difficult things, let's say collarbones or even thoracic outlet syndrome or things at the top before we sort of wander down?
Because the catch blow of those two specialties was threatened.
There's one of the things, Chen. So, what's your operative guidelines for a clavicle fracture? So, someone comes holding their. I've had people sort of drive for a couple of hours, from Whyalla or Sejun or even, because they didn't know what to do. They had an arm in a sling. A non-displacement shaft fracture.
It's very controversial, and you'll get different opinions amongst us even. And certainly in training probably was different to what I do in practice now. Basically, it goes like this. Historically, they've been managed for years and centuries, some would say, without any surgery. So they all, they all do fairly well and maybe don't operate on any of them. And then this Canadian study came out that said that actually they do have functional deficits, return to work and, their ability to function all potentially decrease with these markers, shortening or vertical fragments and all that sort of stuff. And basically where I've landed is probably more towards that side. I'm probably more aggressive. And I guess what it translates for you guys is that it's a slightly more reliably good outcome, I would say, usually with surgery. You can certainly get good outcomes without surgery if they're undisplaced and stuff. You just have to keep a very close eye on them. And I think the acid test is what we kind of do for each other. And, I think I've fixed it. We've all fixed a few collarbones on colleagues and that sort of stuff. And that probably is a bit of an acid test. You don't need to operate on all of them. And in the public system is the very opposite end of that spectrum because they have finite resources. So, I remember as a registrar, I used to say we basically never operate on them acutely and then sort of bring them back to clinic and then judge them on a case-by-case merit. But it would be more the exception rather than the rule that they get operated on, whereas in private, it's, I would say, more common. It's not because they need it. It's mostly just to get a more reliable outcome, I would say.
Right. So if someone is operated on, and Mark might be able to speak to this for anyone who deals with the more elite ones, do they get back to sport quicker if they have a play?
It's always a bit of a, I would say it's probably always a back and forth, isn't it? And I think as I'm learning this more, I think what we say initially at the beginning based on please don't have any complications, it starts to grey out a bit. It'd be interesting to see what Mark says, but I would have thought you'd probably be able to push them a bit harder.
Yeah. So for someone who comes in on a weekend and let's say they don't have the traditional 2 centimeters overlap and things, at what point? Let's say I've got Ali, the registrar, on who's been with us about a month, and I'm trying to say, well, in private, perhaps you're a little bit more aggressive, and you don't have to go by the old public hospital. So, what sort of would be the minimum amount of displacement that we would see to say, look, it's worthwhile going upstairs and having a chat to Chen about the pros and cons?
Yeah, I mean, I think by the book, I would still stick to those numbers, but I'd certainly fix less, I would say. It just becomes a bit unscientific at that point, but mostly you're just chasing for a more sort of reliable outcome. And, we've had ones that are undisplaced and then they don't heal or whatever. And at, 2 months, they're coming back for surgery. But that's, because we're sort of the upper limb team or because we're upper limb surgeons, we tend to catch kind of those outcomes. Whereas if they heal, then they never come to see us. So like I remember, with AC joint injuries, another one where, the grade 3s would always somehow circle back to us. So we tend to be a bit more aggressive, but, by the book, you don't have to fix grade 3s. So
Sure.
I think we sort of have that discussion, and if they sort of want a reliable outcome, provided the scar and all that sort of stuff, then that's fine. But yeah, sorry, it's a bit hedgy, but I would say if it's totally undisplaced, then it's probably hard to justify. If it's even a centimeter or it's 100% displaced, then it's probably not going to be that stable, and it's probably reasonable to have a bit of a chat with them. It will still heal, and what will happen is that it won't reduce, but it will just heal over the top, and then it will sort of even itself out over time. And many people don't need surgery necessarily, but yeah, it's very hedgy. But I would say
that's right. So
generally speaking, low threshold, but
so let's say for the argument's sake it's 50% displaced, but it's not. There's no overlap. You'd let that go unless there's a special reason to get it to length, or put a plate over the top.
Yeah.
Okay.
Hey, Mark, I can answer that question you had about elite players and at the AFL level and SANFL. So they will get a faster return to sport if they have it plated, and most of them are sent for it immediately. All the ones I saw at Port were. So, so I think they would aim to have them play at 6 to 8 weeks, hopefully closer to 6. That's probably at the more aggressive end. There was Lin Jong, who played it 1 week afterwards and rebent his plate, so that's probably not a great case example. But in practicality, the senior doctors who I worked with for many years at SportsMed would not let people go back. So if they had it conservative, would not let people go back before 12 weeks, because not that the bone's not healed, but there's this kind of anecdote that all the people who had let someone go back before 12 weeks conservative had refractured through that original fracture site. So there's something unique about football when it comes to bumping and stressing the fracture site. So that's the kind of rule I have. And especially with kids, it's often a season-ending injury if it happens kind of mid to early in the year.
Wow.
Yeah.
That's really interesting. And thoughts on that, Chen? Is that?
I think that's reasonable. Like, I think probably we've had these discussions before that traditionally we always worry about complications. So, I think probably if you asked some of us who are a bit more conservative would say, 6 is a bit too soon or 8 is a bit too soon. But the truth is that we're kind of working together to try and achieve an outcome, and everyone's adults usually in the room. And so, I think the idea is that, at 6 weeks, there's going to be some healing. The plate's going to take the rest of the stress. It may be reasonable. And, I think one of the things that developed for me over the last couple of years is like the perk scaphoid screws, because scaphoid, fix them or not fix them, they're always difficult conversations when you're at that 2-month mark where patients are pushing to get back. But if you've got a screw inside, just like the plate on the bone of a collarbone, you're a little bit more probably brave to let them start going back. And certainly by perking, you're only doing like a 0.5 centimeter incision. And so you get the benefits of the fixation, i.e. high union rates, etc., screw it in position when you're returning to play, without the stripping of the open dissection. So that personally, that's been a good thing to do. And by the same token, I think collarbone, having them fixed, you can trust that there's a plate on top. And yes, they get funny breaks, and sometimes if they do something silly, they'll break on either side of the plate. But generally speaking, I would have thought you could trust them a bit more to return earlier. I would have thought.
And thanks for that, Rob. So I wonder that there's the same sort of thinking go then. If Rob or Mark sort of seen it too with these grade 3 AC joint disruptions. So if there's no clear sort of public hospital medical textbook tenting and immediate ischemia and that sort of stuff, and we've all seen sort of probably AC joints sort of wire up in the air, and the skin looks like it'll probably be okay, but it's very squishy. I've had certainly patients come in and sort of demand almost an operative reconstruction, as well as footballers who just take it as a sign of it's a sign of courage.
Right.
yeah. I mean, a lot of rugby players think you're not a proper rugby player unless you AC joints are immediately on display. So is that the same, do you think, Chen, or even Rob or Mark?
I reckon probably Rob would agree. It's probably almost the opposite in the sense that unless it's a 4, 5, or 6, and if they can play on it, then I would be more protective. Unlike the clavicle plate, where the plates can take a lot of force, and you can get these people moving early. We're talking about waiting for ligaments to heal up before you're returning them to play. So therefore, it's almost the opposite, where maybe you're better off just letting things heal on their own and kind of seeing what you're left with, and then it might be an end of season thing for me. And certainly, I'm more aggressive for the sort of everyday person, because we see the ones that don't heal up. And my personal approach, again, I don't know how scientific this is that you have two groups: the ones that will do well without surgery and the ones that won't. And usually, like, there's all these different views, and you can do a cross-body view called a Basmati view. And I tried all that. None of that really made sense to me. But what just ended up happening is I would just see these people at about 2 weeks, and then they'll tend to self-declare. So either they will start to, elevate and kind of be fine of the 3s, or they won't be able to elevate. And those ones I'll tend to jump in at the early phase. So I reckon if they're doing okay, if they're the former group where they're moving their hand okay, I reckon just, return them at your convenience or however you judge it. And then if they still have problems, then we can do it at the end of the season.
It sounds like a good time to refer them, or just to review them at 2 weeks. And like you said, do that abduction and play with it and see how sore and unstable it is. And
the majority are fine at 2 to 3 weeks, and the majority will kind of do well. I think I agree with Chen that you're not going to do AC joint surgery in season. I think that's an end of season operation. The advantage is it's different to the clavicle, where you don't have to do it immediately, and it can be kind of done later after potentially a fail of conservative management. So probably quite a few are going to do well. You'll always have people who don't like the cosmesis of their clavicle sticking up there, so they're going to want it done. But the grade 4s probably don't have as much pain because the ligaments aren't on as much stretch. So quite often they do quite well as well. But most footballers are going to leave it alone, especially to the end of the season. But I have seen osteonecrosis of the distal end of the clavicle in a few footballers as well who have left it. Not that the surgery might have changed that much, but they come back with a painful lateral side of their clavicle.
Yeah, so on that, there's a fairly common practice to do distal clavicle excision at the time of reconstruction. And I certainly probably do it for slightly older patient population, and for the young ones, I tend to try to recreate anatomy. But I'd assume that would be linked. And everyone has a slightly different preference. But if you see people doing AC joint fixations plus distal clavicle excision, that's why. Maybe it's osteonecrosis, maybe it's a little bit of arthritis. Like the whole capsule gets stripped when this gets injured. So when you put it back in and expect it to act like it did 3 or 4 months ago, it's probably a bit of a ask. So it's probably not unreasonable to do that sort of stuff as well.
Okay. So for Rob or anyone else dealing at the moment with this NFL, AFL, when would you, or Chen weigh in as well, when would you say, look, you can elevate it, it's time to try tackling? Is there any sort of in the office sort of rules you can do, like bounce on it or compress it, or horizontal flexion? Any office tests that you can say, right, now you're right, you should be, not guarantee you, but you should be right to sort of tackle a bag? Is there any bedside tests you like?
Mark, I'd say just from an AFL perspective, I sort of agree with what's been said. At the AFL level, most of the clavicle fractures are high speed, so they all need to be fixed, in my experience, because they're hit with such force that there always seems to be fairly clear, surgical intervention in the few I've seen, but you don't tend to see that many. And they can come back around 6 weeks, usually pretty comfortably. In terms of the AC joint, Rob's 100%. Virtually all of them you treat conservatively unless they're a real high grade 4 or 5 or beyond. And basically, we just inject them, and then most of them need to be injected with local pretty well every week for the rest of the season. I'd be very interested in Chen's. I don't think the grading system is that great, to be honest, particularly around grade 3s, because I think there are actually different forms of grade 3s, but we actually don't know what they are. My experience of the ones that are the big posterior dislocators that are moving in a massive, particularly posterior, they all seem to need to be fixed because they seem to be unstable, and the players feel that instability over time. So I don't know. I'd be interested in your comment on that, Chen. Do you think we've got a very simplistic grading system, which I don't think is meeting our needs around grade 3?
So when I was doing a lot of reading into this, there was a grade 3A and 3B. And basically what they were suggesting was that if on a deduction like this, the clavicle overrides the acromion, then that would be a 3B and therefore more unstable. And so therefore they came up with these x-rays to test that. I tried a few of them. I could never make heads or tails of it. And basically I just defaulted back to review at 2 weeks and then kind of see what they were doing. But yeah, you're definitely right. Like just the vertical translation hasn't really lent itself to really making heads or tails of, because it's more than just vertical. Most of these are horizontal translations that become the issue. So anyway, so that's kind of where I've landed.
And I know Michael talks a lot about scapular instability, but I must say I don't know how to assess that. I don't know. I don't know if it makes sense to me. How do you assess scapular instability in an office? I don't know.
Yeah, especially if they've got a bit of a buggered shoulder at the moment. Anyway, I have to pick his brain about that. I guess I have a slightly more simplistic view. It's just I understand that there's going to be some sort of horizontal translations that we can't get on a static X-ray. So grade 3s probably, like I said, low threshold, especially for the laborers and stuff. But the high elite athletes, they would struggle to return, and we wouldn't let them return really. So then you just play on.
And they're easy to inject because there's essentially no capsule there, so you can just spray the local around everywhere, and they seem to cope well. And I think all my grade 1s and grade 2s that I inject for periods of time, I reckon they all get that osteonecrosis look around the distal clavicle. But if you rest them for 6 or 8 weeks, that generally recovers at the end of the season. So on that point that you raised, Rob, which I think was a good one, you see, and they're really painful impingement. They can't do bench press. But if 99% of them, if you give them a bit of decent time away from those provocations in the season, they seem to recover well.
Hey, Sess, do you go the early steroid at like on a day 10 just to settle down the ones that aren't settling? So I often, the ones I see in clinic, kind of your Payneham footballer or your Ranella footballer, I'll see them at 10 days, give them anti-inflams. Majority are fine, and then the ones that just aren't settling, give them an early steroid. Do you do that?
Yeah, I think that's not unreasonable because if you can control pain, then that's half of the battle. And then you want to inject them, because I don't like to inject them during training, because I think that's a bit silly unless you've got then you're just adding an extra provocation. So I try to determine which ones in my own mind that I think I'll be able to inject on match day and they'll be good enough to play, which is really a bit of an interpretation experience and how well you know the athlete. Because I said, the more times you inject them, the more sore they are, because obviously you provoke it and you get all that sort of, muscular soreness around. So, but I think, steroids are a good call at 10 to 14.
Yeah. The other thing you should always tell them, and I've injected a few where you inject them for 4 or 6 weeks in a row, is that if they get a good enough hit, the local won't protect them. So, if they get a good enough bump on it, it'll still hurt. So, because they want to know that the local's not going to protect against everything.
But also some of the lower grade ones, they tend to have stripped that periosteum along the clavicle.
Yeah.
And that's really hard because your most effective local block is within the joint. So if they get that sort of periosteal stripping across, they tend to still be pretty sore during match day. You can put a bit of local along that edge, but I don't reckon it works all that well. So that's probably what you're experiencing there, I reckon.
Yeah.
That's pretty good. We'll keep wandering down the arm, and this, I think, this is also the forum to ask sort of silly questions, simple questions, as well as trying to think of the harder ones. But is the shoulder dislocations again? Have you got a favourite technique for getting them back, Chen, or again, what are they?
You guys will be doing that a lot more than me.
Mark and Rob, or Sandy, and anyone sort of dealing with it? Have you got a favourite? Sort of because it seems like traction sort of is out, sort of just causes more damage, and I've never had too much luck with the old Hippocratic method.
So the best one is the player who just comes straight off the ground to get them prone and just apply some traction to their arm. I had one player who came off, and I was really looking forward to putting it back in, and he went to lay prone, and as soon as his pec hit the bed, it slipped back in. So that was
depriving you of the fun.
Yeah, I know. The other technique I've seen when that hasn't worked has been putting a towel under their arm, just putting them into ER. That's worked quite well in the ones I've seen, but I'd be interested to see what Seth says.
Yeah, I said them all. The other thing we often forget is it's really tiring and hard for the guy putting it back in. Like, unless you're super strong, you want to put yourself in a biomechanical advantage as well. So I always sit them on their side, put them over the arm of a chair, get a towel under their armpit, bend their arm, and then it's so easy for you because you can just push down against their flexed elbow, against their forearm. You're just putting a little bit of, and you don't have to push that hard really. And if you want to, you can even maneuver the joint itself back in, you know what I mean? But if you push down against their bent arm, you're eventually going to win the contest. They're going to fail, and it will go back in every single time.
Yeah.
Does that make sense?
Yeah, that sounds good. The if I find it again, I'll show you. I think it was an Australian guy, might have been the Cunningham sort of thing, but he really, it was a modified Cockers sort of thing where they really relaxed the traps, so they really got the scapula back and down, and relaxed them, and then really slowly sort of got them into ER and abduction, and it went in. And I had a bit of luck with a soccer player. That was, like you said, Rob, straight after he came off the field, so nothing had a chance to get into spasm. And I looked like a guru, but thank God it worked. And that was about the only time in recent memory I can imagine them working. I grew up in New Zealand. All these big Samoan and Maori mates would do their things, and they were massive. And by the time you saw them, they were in spasm and they needed a general anaesthetic. So I'm always quite happy when a skinny white fella sort of comes in. That's just me. Anyway, so and back to sort of basics again in a way. Are you happy for that first time dislocators, Chen, to sort of go through the rehab, or are there any?
Yeah. So
if you're calling early.
I mean, I think this is probably one of those that you guys have been managing very well for a long time. Statistically, I'm sure you know this, but you can Google it. I have it on my desktop. But young men tend to redislocate in the first 2 years, like 80% plus. Women is like half of men, and it drops as they get older to sort of tops out about 30% and 15%. So 30% for men and 15%. So I guess, yes, by all means, and definitely, it's usually not it's usually a relocate, rehab, and return to play and end of season type job. And especially with younger men, then you just need to have that conversation with them that, if you're 18, your chance of redislocating in the next 2 years is about 80%. So despite rehab, so whether we think about surgery or not, that's kind of where I see it.
If they have a Hill Sachs, does that sort of change your stats and your conversation?
I mean, that's just all comers without bony lesions and such added into it. I guess for us, where that comes into discussion more is, yes, number one, that will increase that number, but also number two is it may change the discussion, because I guess what's hot at the moment is there's a bit of a shift into Latarjet. In the eastern states, they do Latarjet very commonly. We're still kind of a bit of a holdout for arthroscopic repairs, like provided no bony lesions. But I think even we are starting to, well, I don't know what everyone else thinks, but I think I'm starting to turn my head a little bit more with Latarjet. I think we get good results, that they can be a little bit stiff in ER, but some of mine are stiff in ER, even the soft tissue ones. So,
all right, I'm just getting my head around the French. Is that the bony block one, or is that where you pin it down with infraspinatus out the back? You put a
correct. So the Latarjet is the bone block. Remplissage is the one where you pin it out the back to block, to basically to make that Hill-Sachs lesion extra articular. But I think, anyway, there's also a move overseas to do arthroscopic Latarjet, and there's some guys doing it interstate. But I think the risk to the axillary nerve is unacceptable for me. So anyway, basically it's Latarjet where you make a little incision like this. They do arthroscopic. They quote that in the first 50 cases, there's a risk, or 100 cases, there's a risk to damaging the axillary nerve. The axillary nerve powers the deltoid. If you damage the axillary nerve, the whole shoulder's buggered. So that interstate, there's a guy that injured one, but that was in his first 100. And then the guy that came up with the arthroscopic Latarjet, guy called LaFosse, he injured one like 2 years ago. So anyway, I don't think it's safe. So I have not offered it or won't be offering it. But that is, anyway, there's a bit of a shift. There's a big shift towards considering Latarjets off the bat. Anyway.
That's interesting. It's interesting to know the trends, because patients will sometimes ask, or there'll be a note back from the surgeon. So it's sort of good to know what's being talked about in your circles. But these are questions that just come to my mind anyway, and so Ash or anyone else can jump in. But how does that conversation go too? I'd like, because a difficult one with a hyperflexible 16-year-old girl whose parents, and they're very highly upset because they must win that netball premiership this season with their recurrently dislocating shoulder, and therefore need something done about it. So how do you frame those conversations?
So I guess what you're saying is, how do I discuss with the patients whether they should get a Latarjet or a arthroscopic, or are you saying, how do I discuss with them whether they should even have surgery?
Yeah, that's right. Those hyperlax younger people, particularly the girls, who really you're just trying to buy some time, perhaps, or which ones are there ones you do send on? Because obviously we want to send you your work that you will, not only discuss an operation, but want to actually perhaps operate on. And how do you keep them on side?
It's really hard. So I guess generally speaking, I mean, I'm sure you know this as well, but
we've tended to make them non-contact probably to around 5.5, 6 months. Now, maybe we're just really lucky, but that so far has seemed to be successful, except in some particular cases of really large injuries and recurrences. We had a player from another club where Michael did a Latarjet on the patient. So I don't know. I don't know if that's the case, but it seemed to be very heavily influenced by that little AFL study. So I think the practice of arthroscopic, I think, is still a reason one, in my anecdotal experience. And in terms of what Sandy's saying, I just reckon that I think it's reasonable to have a discussion with any patient and see what they want to do. And I don't think it's a harm to try conservative management. But if they've got any sort of decent anterior labral tear and they're playing any level of football, they just won't be able to tackle, essentially. So I think inevitably you'll be doing some sort of labral repair there, in my opinion, anyway.
Mark, so Mark, those ones really can't play on. You can't jolly them for the rest of the season. Unlike Michael Wilson 15 years ago that Peter Pan.
No, you still can. It just it never hurts to try, because their season is over if they have a reconstruction.
Yeah.
arthroscopic or otherwise. I don't think it hurts to try. It all depends on the situation. If you've got a really young player and your situation is not like you're going to make the finals, then that may influence your decision as well. You might say, well, we'd rather have him available from the beginning of the pre-season, so we'll pull the trigger now. But it's really a horses for courses situation. But many of them, I think it's worth a go at having, particularly if you're going to go in the finals. What's the harm? Like, have a little go at it. If they're in a contract year, they're not going to want a reconstruction. They're going to want to have a crack at trying to play on.
Sure. Yeah, it makes complete sense. And I suppose if they redislocate again, well, then you're pretty much fait accompli, are you? Or
Yeah, 100%.
Yeah. Do you have a comment, Chen?
Yeah, I think the part of the problem with research amongst surgeons is that we all do something slightly different. And so arthroscopic repair, they talk about labral repair, but I personally don't believe that just repairing the labrum is of any significant use. I think it's about sort of capsular labral repair. So and it's maybe hubris, but I also haven't had any, not that they've all any come back to me maybe, but I also haven't had any redislocate and having to convert them to latarjets. But I think possibly where people go down and why the redislocation rate, we quote to patients is 10 to 15% redislocation with arthroscopic, whereas latarjet is like 2%, something like that. So, whether that's because people are just grabbing the labrum and repairing it, that's because that's what you're supposed to do. I don't know. I think I certainly haven't turned all the way, but certainly my threshold for latarjet probably is slightly dropping. And I don't know whether it would just go that way. It would continue to go that way as the eastern states have, or whether, I guess we'll see. Like I said, the eastern states, they just latarjet everybody. I had a guy with a simple bank cart and this had a latarjet, not even a contact player. So I don't understand that. Yeah. Yeah, it's hard, and I do a talk about how none of our tests are that sensitive. There's basically it's like I saw a whole bunch of patients with rotator cuff tears, and in the fellowship exam, I learned that you empty can test this. Anyway, the sensitivity is about 40%, according to those studies. Look, I think they come in two types. So either they're sort of anterior, like a dislocator, so apprehension test is really good, or a posterior labrum, which is kind of, or superior labrum. So posterior or superior labrum, they tend to be sort of the more sneaky ones, where they just present as pain. And so superior labrum, O'Brien's test is very good. I think it's very sensitive and it's reasonably specific, but not always. And so that's the one where you do adduction, thumbs down, hurts, palm up, doesn't hurt as much. And posterior labrum is really tricky, actually. It can mimic as bursitis because anytime you even forward flex, the humeral head rolls backwards onto the posterior labrum. So even some of those sort of, early 20s people that, sound like bursitis, overhead pain, but when you inject the bursa or you scan the bursa, it's like, doesn't do anything. I mean, to be frank with those younger ones, we're doing MRIs anyway, so you'll find out pretty soon. But I think my personal opinion is if they're younger and they've got sort of a little bit unknown pain, you probably need to go all the way to MRI because it is likely going to be labrum or that's higher on your differential list. And ultrasound won't tell you, so you pretty much need to go to an MRI, I would thought. The need for MRI arthrogram are not so common anymore. I've done it in a handful, but that's not my sort of go-to. I tend to go plain, and then if they haven't found it on plain and I'm still highly suspicious, I'll go arthrogram. but these days the resolution's good enough. They don't need to go. So let me bring Kevin in. Yeah, these days the resolution's good enough. You don't need to do it, I would say. Yeah. Yeah, yeah. I don't know. Yeah, again, you guys have been doing this for longer than me, but my personal take is I've probably sent 3 or 4 patients off for arthrogram because they just look like they were a labral tear and that wasn't reported. So I just wanted to get to the bottom of it for them. But most of the time I haven't needed it, I would say. Yeah.
Mark from Sandy here. Not particularly that adds to what Chen's just said, really. And yeah, look, low threshold to go to MR in every dislocator, especially the young. And my experience being an old doctor but a young registrar, yeah, look, the MR sensitivity is so good these days that you hardly ever. I've never ordered contrast, and I think if you get the MSK guys to do it, they're pretty good at picking it.
Yeah.
That's just my experience over the years. Could I ask Chen, sorry, it's Sandy, when you do the lap J,
Yeah.
now, I've been assisting shoulder surgery for a little while, and I've only seen one in 15 years, and that was like 3rd time dislocator.
Yeah.
What's your does it affect your range out the other end? And as a result, is it really not a great operation for the first time, as we might suggest here in South Australia compared to our Victorian colleagues?
Yeah, I have a lower threshold. I probably do maybe 4 or 5 a year, and the vast majority are like redos for other people, like patients weren't happy with the regional surgeon, that sort of stuff. Luckily, I haven't had to do one of mine yet, but I mean, I do tell them that there's a risk of redislocation, but I think it is a bit of a scary operation for some. It's near the nerve, and you only have so much coracoid and all that sort of stuff, but I would say all of them, especially the ones that are redislocating after arthroscopic surgery, are super happy, and they tell me they wish they had it done like that the first time. I mean, that they're obviously, that's understandable for them, but they certainly feel more stable, and you can push them a bit harder to begin with because you're not waiting for that capsular labral tissue to heal back on. You've got a block of bone that will kind of protect you. My rehab protocols are the same, but like secretly, I kind of let them go a bit freer, I would say. I don't think it's.
Can you elaborate that? Just your rehab protocol, just for the group.
So, most people do 6 weeks in a sling, like strictly, no ER, for both arthroscopic and for lattice J. I do 3 weeks strictly in a sling and another 3 weeks kind of loosely, if that makes sense. So they can come out, but they need to stay within certain boundaries. So it's safe zone A, but no ER beyond neutral, no elevation above shoulder type thing. So I'm still giving it 6 weeks to heal up, but I'm kind of letting them move a little bit more in the last 3 weeks. We all have, I guess, generally speaking, everybody has, we all use what's called an orthopedic unit of time, which is about 6 weeks. So 6 weeks doing this, 6 weeks doing that, 6 weeks doing the other thing. And so usually for the first 6 weeks, you just want to let the tissues heal. Yeah, so I kind of still stick to that, but I would say probably for the last 3 weeks of that 6 weeks, especially for the Latarjets, I'm probably happy for them to push a little bit harder, come out of the sling around the house a bit more, that sort of stuff. Just because you're not relying on tissues and sort of few sutures holding things back together. There's a block of bone and there's screws holding it, so a bit more confident perhaps. So the question was, you've only seen one Latarjet. Is it good, and do patients, are they happy? Yes, they are. The slight argument against that is that if you look at people post Latarjet plus post Bankart repair, arthroscopic stabilization, the post Latarjet patients have slightly higher rate of OA, and the counter argument towards that is that maybe these are more traumatic injuries in the first place. That's why they had the Latarjet. So I think traditionally that's been something to argue against, and also the risk of neurovascular injury and all that sort of stuff. But I think especially open, you can see what you're doing. It's not as dangerous, and it's only like this kind of incision. And like I said, the ones that I've done where they've both had arthroscopic and open, they come back to 2 weeks and say it's no worse than keyhole. So I guess it depends who does it and how experienced and all that sort of stuff. But anyway, but I'm not a zealot for Latarjet, but I know that there is a trend, and I haven't felt the need to, because I think the arthroscopic ones still do fine, more than fine. The other downside is the ER, lack of ER. So theoretically, you have up to 30 degrees lack of ER compared to the contralateral side. Because I push them a bit harder, I'm sort of let them freer maybe at 3 weeks. I think in my patients, I would say maybe 20. So for for footy players, rugby players, no problem. But for other, overhead athletes, goalkeepers, it may be a bit of more of an issue where they really need that external rotation to wind up. So that would be the discussion to be having, I would thought. Yeah. I normally push that onto the physios, to be frank. I do have a little protocol that you can download off my website and just go see the physios. But basically at 6 weeks, the sling comes off for good, and you're sort of pushing range, and you're just gently pushing strength, but mostly range. Yeah. And then another 6 weeks, then you're pushing strength. Okay. Like I said, I think one thing, I've had a couple of sports guys in theatres for, the perk scaphoids. I think that's a good one. If you see them, they're absolute heartbreak sometimes to manage non-operatively. I'm sure you've all been in the room, but guys begging you to go back at 2 months, no. and so it just I think it makes that discussion easier with the screw in. I think, I don't know Ash, whether you wanted to have a chat about an injury that happened in the family, or?
Yeah, we can talk about my silly brother, who is a city boy who should have not bought a farm, and certainly shouldn't have bought a quad bike. So he kind of tipped it over and landed, I think, on his elbow, or an outstretched hand, and dislocated his elbow, and did a very good job.
I mean, I can't imagine a lot of you guys will see this, but you might see elbow dislocations, which were probably more topical, but basically it was something called a terrible triad injury, where you have a dislocation, you have a radial head fracture, and a ligament injury. So dislocated at the scene, reduced in the country hospital, came back, and then we had to fix it. Usually these are quite smashed, needing radial head replacements. We managed to get away without doing that, but had to do a ligament repair. But he'll be tricky to rehab, to be frank, because elbows are always a balance between too stiff and too loose, because we're dealing with instability, but elbows get stiff, right? So the idea is you stabilize them enough that you can move them a bit, but it's tricky. But I think what might be more topical is things like just simple elbow dislocations. Did you guys see that or not? You would be like it. Very rarely you'd see that.
Chen, I had a posterior dislocation. So I had a
Yourself?
posterior dislocation. No, not myself, luckily.
Okay.
It was one of the footy players. It's one of
Yes.
the footy players when I was covering the Sandfeld, and basically he went to land a tackle, but his opponent was coming towards him, so he was trying to get his arm around him, and then somebody else kind of levered on his arm, and
Yeah.
so it was you could see it. He's coming off, and you could see the dent on the posterior aspect of the elbow. Not fun. And
No.
obviously, as you'd expect from any dislocation, just quite painful. So he's a tough nut. So I actually relocated it on site. Pulses were all good. He's happy. And next question is, can I go back in with tape? So,
Oh, jeez.
the next level. But it, it clearly can happen. My understanding, Chen, is if you're dislocating an elbow, though, is like the elbow is a pretty sturdy structure from its bony components. So it was quite unlucky. But he actually ended up quite well. Obviously he got some X-rays, which were fine. I actually did an MRI just to make sure that chondral surfaces were okay. And he actually got away with murder. So there was really nothing, no laxity, nothing from the elbow. So it was a massive win for him. And just slowly recovered over the next couple of weeks, to be perfectly honest.
Yeah, so this is another one of those things that we get lied to in training. So elbow dislocation, exactly as you said, it's a hinge. It's a very sturdy hinge, and to dislocate it, you pretty much need to do everything, right? What we're taught is that it's a hyperextension injury. It starts on the lateral side, so you break the lateral collaterals and it strips around the front. So you break the lateral collaterals, you break the anterior capsule, then the last thing to go is the medial collateral ligament. But they did where I went on fellowship very briefly for 2 months, they did a MRI study where they MRI'd all the elbow dislocations, which we don't often do. You guys can, I guess, but it just doesn't happen in public, certainly. And what they found was that every one of them had the medial collateral ligament gone. That was the start, actually. So it means that these are often huge soft tissue injuries, but if you do treat them a little bit with benign neglect, they will stiffen up a bit because the elbows get stiff. And so I guess, how does that translate into practice? I guess how my practice is unless they're a fracture, you can, or an industrial injury where they've done something really bad. If it's a simple dislocation where they've hyperextended and popped their elbow out, even though they've probably stripped all of their collaterals, they will probably be okay without surgical treatment. And so you can MRI them, obviously, but you may not necessarily change what you do. And, unless they're very unstable, you don't tend to fix them. So usually it needs something bony to go as well to make them that unstable, in my hands anyway. And so what do you do? Well, they're unstable in extension usually. So I would put them in a sling for a couple of weeks, let things settle down. You could put them in a backside for a couple of weeks. And then from 2 to 6 weeks, you probably want to get them moving at that point. And again, the danger is full extension. So you might say, okay, 30 degrees of extension to full flexion. Flexion will be very safe. The other thing that they were doing, where I went to fellowship, was they were doing the range of motion supine. So again, because gravity will be keeping it end located as to doing this extension where gravity will be dislocating your elbow. That is a bit harder, and what they found was that actually in that position they got more movement because it felt more stable, whereas you kind of have a natural apprehension. If it feels like it's about to pop out, you just won't do it, if that makes sense. So yeah, so elbow dislocation, end locate. So Kevin would have done traction and hyperflexion, and you could hear a pop usually. And then just sling or plaster for 2 weeks. You need to do x-rays, obviously, to check everything's back in place. You could do an MRI, but you'll see carnage. I'm sure Kevin saw that. But yeah, I would slowly get them moving after that. If there's any fractures, that changes the scenario, because then there's also bony deficiencies that may make it more unstable. So they sometimes might need MUAs, or, you know, depends on the injury. But yeah. 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 That's okay. Yeah, I think that's okay. It must have been that 40-minute limit. But anyway, it's good to have a chat. Good to, yeah. No, just
Thank you very much, guys.
thanks.
Mark,
Thanks,
great.
Thanks, Jen. Thanks, everyone.
Hey, Mark, for the accreditation, do we need to upload ourselves, or do you that for us? You know how we can run CPD portal?
That's okay. Just sharing ideas.
Thank you.
See you guys.
Thanks,
All right, see you,
everybody.
everyone.
Thank you.
Bye.